AZCCC presents the Cancer Care Podcast, Arizona Center for Cancer Care. Comprehensive care with the highest quality of cancer treatment in Arizona. Joining us today, breast surgeon, Dr. John Davis.
Yes, breast surgeon and one of our newest stars at Arizona Center for Cancer Care and Comprehensive Breast Centers of Arizona, breast surgeon Dr. John Davis. How you doing?
I'm good. Thanks for having me.
You know, before we get into this, you're still fairly new at AZCCC. A couple months?
About 2 months, almost 2 months.
Okay, about 2 months. I just want to know about you. You're Chicago, right?
Yep. So I'm from Chicago, Illinois. Raised and grew up there in Hyde Park. And then for undergraduate, I went to University of Illinois in Champaign, so Big Ten. I did cheer for Ohio State a little bit.
Hyde Park, is that north or south side?
South side.
All right.
So that's around where Obama, where he lived.
So you're White Sox?
White Sox. You have to be White Sox on the south side, north side, Cubs fan.
And then Soldier Field's kind of in the middle, so everybody kind of pulls for the Bears. Is that the deal?
One football team, so you go for the same team.
Okay. And then you were talking about Big Ten?
Yeah, so Big Ten. I'm a big football guy. And then for medical school, I went to Medical College of Wisconsin in Milwaukee. So I kind of stayed in the same area or Midwest. For residency, I wound up coming out here, Phoenix, Arizona. Never
became a Wisconsin Badger fan, though.
No. If you're from Chicago or Illinois, you can become a Badger fan or a Packers fan.
Yeah. Chicago's interesting. What was it like growing up there? What was your first concert?
So I was into hip-hop, kind of growing up. I think that the first CD I ever had was Eminem. I went to one of his concerts.
And what else did you do growing up in Chicago?
As I said, I'm a big football fan. So when I started growing up, I was watching actually Randy Moss and the Minnesota Vikings. So I was a receiver based off that. And I played football growing up. And I
was going to say, because you look like Mr. In Shape.
Not as much now. Not as much now.
Let me guess. Wide receiver.
Randy Moss. Yep.
You were fast?
I was fast enough, yes. I did track. I did football and basketball.
What in track?
So I did the short distance, so 100, 4x1, 4x2, 200.
All right. And you still go back, family there?
All my family's in Chicago, so it's just me, my wife, and my daughter.
So why Arizona?
I was in Wisconsin in 2013-14. It was the winter. And
Got it.
So it was the winter time, so I had an interview out here in January. So it was negative 20 inches of snow out there, and then it was 80 degrees out here, no jacket, and that kind of sold me for the most part.
See, I've always told AZCCC, interview in January, and you got them. We get the breast surgeons from all over the nation, like Dr. John Davis, because we interviewed him living in Wisconsin in January in Arizona. You mentioned your daughter?
Yep.
One kid?
One kid.
Okay. How old?
4 years old. 4 years old, going on 30 years old. But
does she have you just wrapped?
For the most part, I spend a lot of time with her, and she's a big daddy's girl.
Breast surgeon, there's some pressure in that job. It's not always a happy job. It can be challenging. You have tough conversations with patients, but you get home and the little girl just must give you balance in your life.
The main thing is definitely kind of have that work-life balance, and coming home, seeing a smile on her face, my wife's face, when I get there is kind of the thing that helps me keep going.
Does your wife like it here?
She loves it here. She loves it here.
All right, so she's Arizona forever now?
I think so. I'm pretty sure.
All right, because we got to keep you. Because 2 months in, everybody loves Dr. Davis, so I'm just checking it out there. Let's get into your specialty, your expertise, breast surgery. Why'd you choose that?
So I was a second-year resident, so I do a lot of research. And during that time when I was a resident, I did my breast surgery rotation. The main thing that I really enjoyed about it is that for the most part, you catch these cancers early. So screening mammogram, we have a way to screen for breast cancer, and that's how we catch these cancers early. So if we actually catch the cancer early, operate, plus minus chemotherapy, radiation, they have a successful long life ahead of them. So seeing these patients from the beginning when they first get diagnosed, how sad they are, how upset they are, and kind of moving forward to the surgery and recovery, kind of have a lifelong partner and patient, that kind of brings me joy for the most part.
As a breast surgeon, is it all cancer that you're working on, or do you do other types of procedures?
So as a breast surgeon, you do anything related to the breast. So benign disease, malignant disease. Majority of the patients that we do have are benign disease. So breast pain, breast lump, breast masses, nipple discharge, things like that.
But not reconstruction.
From my standpoint, I don't do reconstruction. I'm more on the oncology side, so I take the cancer out. We have a team of plastic surgeons that kind of do the reconstruction from there.
What's that like for you working around augmentation, especially in Arizona, Scottsdale? a high percentage?
So I think that, it's pretty based on the population that you do have. More of the younger patients do want reconstructive as opposed to the older patients who really don't care. They've kind of lived their life for the most part, so they really don't want reconstruction as much. But you do find a high number of patients getting reconstruction here.
With the younger patients, I imagine you really have to pay attention to cosmetics and protecting the nipple as much as possible because they have a whole life ahead of them and cosmetics are so important to them. How much of that comes into play during your surgery?
From a nipple-sparing mastectomy standpoint, it's really only a certain population, so a certain breast size. So if you kind of have on the larger spectrum, you wouldn't necessarily be a candidate. But you do kind of have to pay attention to that. The one thing that I do discuss with them is that it's more a cosmetic outcome. So you don't have nipple sensation. You really don't have that much breast sensation after mastectomy. So it's more a purely cosmetic standpoint.
Do you do some of the more simple excisions like lipomas?
I do lipomas. So anything related to the breast. So fibroadenomas are fairly common in younger patients, and they kind of grow. They're non-cancerous. So we do wide local excision or excisional biopsies of that. We do lumpectomies, but we also kind of do the spectrum all the way up to mastectomies and reconstruction.
Is the most challenging part of your gig the surgical procedures or dealing with the patients emotionally?
I've always been in academics, and I think the most challenging part is learning how to run a business for the most part. I've had great training and dealing with the patients and kind of dealing with the management of the breast cancer is the easy part. So learning how to run a clinic and things like that is the more challenging part. But over these 2 months, I've definitely learned a lot kind of working with AZCCC.
Yeah, obviously, I mean, you're highly educated, but in med school, they don't really teach the human interaction, nor do they teach the business side.
Right. Those are two things that you kind of have to pick up going along the way. So the human interaction and the patient, physician interaction kind of goes along with the residency. So learn how to talk to patients and kind of deal with them on that perspective. But from a business standpoint, I think that's one thing that's missing in the surgical education or medical education in general.
Let's talk about different types of options for those diagnosed with breast cancer. Depending on the location, I'm sure, is a variable that makes a big difference. Overall health of the patient. What are some of the options available?
So when they come to my office, I usually give them a packet, like you said, based on where the location of the tumor is. I give them options. So just kind of starting from the beginning. Lumpectomy, what we do is talk to them about a lumpectomy. So taking a portion or a small portion of the breast, so the tumor and a small surrounding area so you have a clear margin. So we do a lumpectomy, but also discuss that if they do get a lumpectomy and have breast cancer, then they do have radiation. So there sometimes...
They always do.
For the most part. There are certain variations where you don't get radiation, but for the most part, I always say lumpectomy plus radiation. We say those have equal survival benefits as mastectomy, which is removing the whole breast. And there are different types of mastectomy. So there's skin-sparing mastectomy, where you take the nipple but keep the envelope of skin. There's nipple-sparing mastectomy, where you take all of the breast tissue but leave the entire breast skin and nipple as well.
Mastectomy still followed by radiation. Correct?
So what we say is that lumpectomy plus radiation is equivocal to mastectomy. Are there times where we do have a mastectomy patient and we give them the radiation? Yes, but there are certain criteria for that as well.
Are you part of the diagnosis at all?
Majority of the time, patients come to me first, and then I work them up. I do their biopsy, and then most of the time, I'm the one kind of breaking the news to them about the cancer. Sometime they do come to me already worked up with the biopsy, but it depends on when I encounter them.
So you're the point of contact right after the biopsy?
Right after the biopsy, they have an abnormal mammogram, abnormal biopsy. For the most part, I'm the next contact. Or if I do the biopsy, then I usually follow them up with the results.
So you are the one presenting options?
I do. So they come to me and I kind of present the options, and then I dictate, kind of based off the surgery, if they need plastic surgery, the medical oncologist and radiation oncologist.
Breast pain always mean breast cancer?
No, actually I did a study, and about 90% of the time, people that actually go to the emergency department or kind of get worked up for breast pain does not equal breast cancer. So when patients come, I give them a packet that I made as well, going over that pain is not really associated with breast cancer, unless it's like on the chest wall or invading the skin. But for the most part, it's not related to breast cancer.
People doing self-checks, they feel a lump, they're in panic mode, but that doesn't always mean cancer.
Not always, as I kind of talked about earlier. So fibroadenomas are one common thing. So in the premenopausal patients, the main thing I would say is if you do feel anything abnormal, so we do kind of go over self-breast exams. So at least, once or twice a month during menstruation and when they aren't having their period, checking just to kind of get their normal contour, make sure they know what normal is. So then anything abnormal, they should go see a physician.
Yeah, because The internet, it can be a great friend or it can be an enemy. And what people find on the internet in terms of how to do self-checks, that has to be somewhat frustrating to you as a physician at times.
I think for the most part, it's kind of half and half about patients kind of doing self-breast exams. But if you look on the internet, everybody has cancer. Everybody's going to die within the next month or so. But for the most part, I think that, if you are doing a breast exam, I think you're halfway there.
If a patient has cancer on one side, is it higher odds that they'll get cancer on the other side?
They're at an increased risk of breast cancer, but kind of depending on the tumor marker. So once we get a biopsy and it shows that they have cancer, and we look at tumor markers, so estrogen receptors, progesterone receptors, and HER2 receptors. So if they have estrogen and progesterone receptors that are positive, we can give them medication, or the medical oncologist give them medication that actually reduces the risk of breast cancer by 50% on the other side.
Wow. As a surgeon, do you do everything robotic these days?
I wish. No, so from
Oh, really? There's still some hands-on stuff?
There are some hands-on things. Funny that you mentioned that. So they're doing trials for robotic nipple-sparing mastectomy. So it's a guy in Italy who actually does this. So they have some trials ongoing in the United States looking at robotic nipple-sparing mastectomies.
Why wouldn't that be underway already? Why is that robotic procedure later than the others?
So the thing is that with the FDA, they want to regulate things, which is understandable. So in Europe and other countries, they kind of have more of a lenient process, so they get to do things before we do. So they do have ongoing trials now, but for the most part, it's on a clinical trial.
When I asked you about robotic surgery, you said, I wish. Is that because the success rate is higher, or is it easier on the surgeon?
I think the one thing is that as a surgeon, and when you're in these long procedures, you do get tired. Your neck get tired, your hands get tired. But during robotics, you do kind of have more mobility and more visualization that you don't necessarily get when you're doing open surgery.
What's it like in the surgery room? I've heard everything. You guys play your favorite music or whatever you want.
Yeah, usually get on YouTube, Pandora, put some music on and just kind of get in the mood and get ready for surgery.
Have you done so many surgeries that you can talk about the Bears game or talk about what you're doing this weekend? Does it become that routine?
I think that for the most part, once you kind of get in the process and get in the mode, just as you go to work every day, you're comfortable speaking on the radio. So I'm comfortable in the operating room. The main thing is we do talk about things, but we still stay focused. Every surgery is different. Every patient is different. Every operation is different.
So the analogy that you've heard a million times as a surgeon, you're probably tired of hearing, but I'm just curious, is it really like a video game?
So if you're doing like an EGD or a colonoscopy, maybe so. Robotics, maybe so. But I think open surgery is a little different.
Yeah, the coordination for robotic, it just looks difficult to me. It looks like everything's in reverse.
The main thing is more the spatial awareness and the tactile feedback. So one important thing is that if you're operating doing open surgery, you actually have tactile feedback. You can touch, you can feel, you can see. But when you're doing robotics, you don't necessarily have that tactile feedback. So you may be pulling on something harder or softer than you actually think you are.
As far as public awareness, what would you like people to know more about breast cancer and breast surgery? We touched on some of the myths that fly around or early panic before getting a true diagnosis, a biopsy. But what would you like people to know more about with public awareness?
I think the main thing is actually going out there, getting checked out. So I do genetic screening and I do genetic testing as well. So if you do have a family history of breast cancer or any cancers in general, you should definitely see a physician and talk to them about that or possibly genetic testing. In addition to that, I think that the first step is actually going out, getting the screening. So depending on what recommendations you read, but usually I say at the age of 40 is when you should start getting your mammograms.
Oh, I thought it would be earlier than that.
So for the most part, and like I said, with different recommendations, if you do have a higher risk of having breast cancer, they usually say 10 years younger than the earliest family member.
How do people contact you?
So they can call me, they can fax me, they can look my phone number up or look up the website.
Yeah, a good way to do it is just go to ArizonaCCC.com. And he's a Bears fan and he's a White Sox fan. Got to be a Blackhawks fan.
I'm not a big hockey fan, but they did win the Stanley Cup not too long ago, and I did see some of those games.
And a Bulls fan.
Bulls fan, for sure.
Never talk to me about the 92-93 NBA championships. It still hurts, man, okay? We're still broken here in Arizona. So with your family living in Arizona, just don't bring that up to anybody. John Paxson is not a name we want to hear.
They did just get Chris Paul.
Okay. Yeah, we do have Chris Paul now. We gave a lot for him, and we're paying him like, Hopkins money. Yeah. Why didn't you take the Hopkins contract of, $50 million over 2 years?
I'm not sure. The basketball players actually just get paid so much money, and it is guaranteed money compared to the football guys.
Yeah. Breast surgeons are in it for the right reason.
Absolutely.
To help patients. And congratulations on your career. Hello to your family, and thank you.
Thank you.
Dr. Davis.
Thanks for listening, and please join us again for the Cancer Care Podcast, presented by Arizona Center for Cancer Care. For more information on the highest quality of cancer treatment in Arizona, please go to arizonaccc.com.